ABC provides a logical progression for an assessment, and it's easy to remember. It puts airway, front and centre and breathing. Without these you'll die very quickly, then moving on to circulation, disability and exposure. Whilst in the real world you may notice something immediately that fits into exposure, for example bleeding, this framework reminds you to check all the other elements as part of the approach. As soon as you are concerned about your patient, get yourself some help. Call for help, or if need be, pull the emergency buzzer. No emergency situation should be handled by one person on their own, regardless of their experience or knowledge. Whilst it may go against your instinct, it is essential that you stop and apply appropriate PPE before you interact with a patient. This is to ensure that you remain safe and able to continue caring for that patient and your other patients. As soon as we begin to approach our patients, we will automatically begin our assessment. How do they look? Do they look comfortable? Are they slumped? Are they awake? Is there any obvious sign of chest movement or breathing? Do they look cyanosed or blue? Are they conscious? Are they talking to you? As you then move in and you've applied your PPE, we can get into applying things like oxygen saturation monitoring. If a person can speak, then they have at least a partially intact airway. If they are able to make words without any difficulty, then you do not need to be concerned. Even if what they're saying doesn't make sense, for example they may be confused, there's obviously a problem, but it's not their airway. Consider if there are added sounds. Is there obvious secretions or blockage that may be partially occluding the airway? As already mentioned, please ensure that you have appropriate PPE before touching a patient or trying to assess them by direct interaction. If you are concerned, please call for help. As soon as you are concerned that the patient is not maintaining their own airway, then you must take action. As already considered, without an airway, we will not be able to survive. If the patient is not awake, then position them on their back. If the patient is vomiting, then consider the recovery position. Once you've got them in an appropriate position, then look at getting the airway open by utilising the jaw thrust or head tilt chin lift manoeuvres. However, remember that you need to remain in place and hold the patient in an appropriate position to maintain the airway. You may then consider putting the 15 litres of oxygen via the non-rebreathe mask in place. The other option is to protect the airway with an airway adjunct, which are considered on the next slide. Firstly, please ensure that you are familiar with where the airway adjunct equipment is kept on your ward and on your arrest trolley. The nasopharyngeal airway is appropriate for a patient who is awake or semi-awake and needs some help maintaining their airway. Please note that you can suction down a nasopharyngeal airway with a soft suction catheter. The oropharyngeal airway is appropriate for a patient who is not particularly responsive. If a patient is even partially awake, they may push this airway out. Please also note that you cannot suction through a oropharyngeal airway with the soft suction catheter because this endangers the patient by possibly causing gagging and vomiting. However, you can suction around the airway using a yanker. Once you are happy that the patient's airway is safe, you should look at the respiratory pattern. Does the patient look comfortable? Are they struggling to breathe? Are they struggling to talk? what is their respiratory pattern and rate. Consider getting an oxygen saturation monitor as soon as possible, but do not leave the patient on their own to go and fetch equipment. Call for help and get some support. Remember, unless a patient is known to have a respiratory history such as asthma or COPD, you should generally not be able to hear a person breathe. For example, even now, though you can hear me talk, you cannot hear my breath pattern. Therefore, if you can hear a patient breathing, there is something abnormal going on. When possible, get a stethoscope and have a further listen. Even if you can't name the specific abnormality, you should then be able to describe what you hear when the senior nurse or doctor arrives to help. Again, are they getting out of breath as they try to talk to you? In a respiratory assessment, it is important to consider how hard the patient is working to manage their respiratory efforts. Are they using accessory muscles? Are they sitting in a tripod position, or do they look uncomfortable? The more someone has to work, the less time they can manage to do it. So if someone's work and breathing looks as though it's increased, you need to get some help and an assessment as soon as possible, because no one can carry on with that kind of effort for very long. Once you have pulse oximetry saturation monitoring in place, you can consider whether it is appropriate to titrate the oxygen down from the 15 litres via the non-rebreathe mask. Unless you have documented history or can establish that this patient has COPD and therefore can survive on a lower oxygen, aim for saturation of 94% plus. It is more important to oxygenate than it is to be overly concerned about the hypercapnia or elevated CO2, as hypoxia is immediately more dangerous than hypercapnia. You have 4 minutes before someone may suffer hypoxic brain injury. Therefore, get the oxygen on and consider titration only when it's safe to do so. By this time, it is hoped that you will have some help. Please ensure that the appropriate measures have been put in place in regard to position, suctioning, oxygen. And then, once you have support, we can go into more complex interventions such as blood gases, nebulizers, possibly getting chest physio and support from the extended team such as outreach. As you're approaching the patient, you will be able to see what the patient looks like. Do they appear pale? Do they appear shut down? Is there any obvious signs of bleeding? Once you're involved in the patient's assessment, consider urine output, 0.5 mL per kilogram per hour. Do a manual pulse and blood pressure. Consider temperature and capillary refill time. Capillary refill time should be assessed on the sternum by pressing for 5 seconds and then releasing the pressure. The colour of the skin should return to normal within 2 seconds. This is a good indicator of how well filled a patient's vascular space is. Pulse and blood pressure should be checked manually. There are 2 reasons for this. Firstly, pulse oximeter will give you a heart rate, but it will not tell you anything about the rhythm or the strength of that pulse. And the Dynamat machines are known to only give an accurate blood pressure above 80 milligrams of mercury. In addition, when you feel or record the observations manually, you will be able to assess what's happening with that patient's heart rate and vascular state. For example, is the pulse strong and bounding or weak and thready? This will give you an indication of what kind of shock this patient may be in. In the same way, when you're listening for the blood pressure through your stethoscope, how easy is it to find that? How strong is that heart flow? You can then use this as part of your handover when your help arrives. Temperature is a useful part of the overall assessment of an unwell patient. However, it is not a red flag for sepsis. It should be noted that it is entirely possible that a patient can be very unwell and have either a normal or low temperature. When we audit in regards to sepsis, one of the elements that is the least complied with is the maintenance of accurate fluid balance documentation. Urine output is a useful indicator of organ function and should therefore be recorded as accurately as possible. If it is not recorded, then try and find out when the patient last passed urine, assess the bladder, perhaps do a bladder scan and catheterize if indicated. There is a separate presentation in regard to sepsis. However, it's worth considering as part of your A2E assessment. Could this patient be septic? This picture shows a simple illustration of things to be considered. Is the patient shivering, hot or cold? Are they complaining of pain or general discomfort? Are they pale or discoloured? Do they have a rash? Are they difficult to rouse or newly confused? It is recognised that very often patients who are awake enough to respond feel an imminent sense of dread when they have severe sepsis and may say something like, I feel like I may die. And it's not uncommon for someone to be short of breath when they're becoming septic because of the increased requirement for oxygen as they become unwell. Sepsis occurs when the immune system overreacts to an infection. It leads to the excess release of cytokines, and this causes a dysregulation of the immune system. The primary effect of this excess release of cytokines is that the vascular system becomes vasodilated. Therefore, there is insufficient volume of blood to fill the available space. The illustration of the jug and the glass of milk shows that the same amount of milk does not fill the jug even though it fills the glass. Therefore, blood pressure will drop. The sepsis 6 consists of 3 elements that go in and 3 elements that come out. Firstly, as mentioned, oxygen. If the patient becomes acutely unwell, their oxygen requirement will go up. Secondly, IV fluids. As stated, the vasodilation that occurs secondary to the cytokine release will mean that the blood volume is insufficient to maintain blood pressure. Thirdly, and perhaps most importantly, antibiotics. The only way to stop sepsis is to treat the infection that has caused it. We take 3 things out: blood cultures to refine our antibiotic prescriptions, lactate that indicates the level of sepsis. A lactate should be less than 2, and anything above that could be indicating that sepsis isn't a factor. And also finally, urine output. Urine output should be 0.5 mils per kilogram per hour. If it is less than this, then organ dysfunction is a problem. As soon as you are concerned, call for help. Make sure that IV access is available. If you are unable to insert this yourself, get the equipment out ready. Get the blood bottles etc. available. Get the blood culture bottles out. Consider if additional support is required. Have a look at the fluid balance chart. Consider catheterizing only if you feel there is a risk of retention or that the patient is acutely unwell to a level that requires monitoring. And use the sepsis screening tool and sepsis 6 pathway document, which should be available on all wards. Disability assessment. In the A2E assessment framework, D for disability is the least obvious of what it means. It actually stands for disability of the mind or brain. Within this assessment, we have the word gaps to remind you of what to consider. Glucose. What is the normal range of glucose? Greater than 4. Just remember that even someone who is not diabetic, when they are an inpatient in a hospital, will be in an abnormal circumstance for them and may not be eating or drinking in their normal pattern. So if they've dropped their level of consciousness, what's their blood sugar? Level of alertness, we will look at the NAPU scale on the next slide. Pain will change both behaviour and physiological observations. If someone is in pain, they may be more agitated, they may have an elevated heart rate or blood pressure. Pupils will also be looked at the next slide. Seizures. Are they epileptic? Have they got a very high temperature? Seizures caused by temperature are more common in children but do happen in adults. Are they on drugs or withdrawing from drugs? Consider all these factors in looking at the patient's level of consciousness and response. NAPU is a simple tool used to assess the level of consciousness of the deteriorating patient. Please note that there is a more comprehensive presentation specifically around this subject available on the Acute Care Team's website. We consider new confusion as a concern because it may be an indicator of hypoxia. When we say A for alert, we want the patient to be at their baseline. If we do not know what the patient's baseline is prior to meeting them, we assume that any abnormality is new until we learn differently. When we look at V for voice, this means that you speak to them and then you may have to shout to raise your voice because they need to be able to hear you. Assume they're deaf, shout in their ear. If they wake up and are fully responsive and say, "Why did you wake me up? Please leave me alone," then they're actually alert and they were asleep. But if they remain lethargic or semi-responsive or localizing, then they're responding to voice. The same goes for pain. If you inflict pain on someone and they wake up and tell you to go away, then they're actually alert and they were asleep. However, if you inflict pain by squeezing on the trapezius muscle, which is the only way that we advise anyone do this, and they again don't fully wake up, but they do maybe have some grunts and groans and perhaps localize, maybe are lethargic and not fully responsive, then they're responding to pain. If you've inflicted pain and there is no real response or only minimal, then they're unresponsive. Pupils equal and reacting to light. Please ensure that you use only the appropriate tool, which is the pupil torch, for assessing a patient's pupils. This is because it is at an appropriate level of brightness and it also handily has the sizes on the side. Each pupil should respond briskly and then expand again at the same rate. It must be considered whether the patient has got any known injury or disability that may affect their eyes. For example, have they got a glass eye, or have they recently been to the opticians and had drops in, or do they have a pre-existing head injury that may affect their pupils. However, as in all signs, assume that anything abnormal is new. We manage disability in relation to what we find. Firstly, following ABC, we maintain the patient's airway and ensure that their blood pressure and heart rate, etc. have been considered. Then we will treat blood glucose, treat seizures, manage pain. Then consider using the Glasgow Coma Scale for a more refined assessment of their neurological status. Head to toe, front to back, look at everything. Assume any change or abnormality is new. Document your findings and hand it over appropriately. If it's not safe to turn someone, then do the best you can do. Slide your hand in with appropriate PPE to check for any bleeding or fluid loss, but only if it's safe to do so. Hopefully by this time you will have some help and support. S-bar. This is a tool to facilitate effective communication. Situation, background, assessment, recommendations/requests. This will give you a format to hand over the information that you have gleaned during your ATE assessment and then to request a plan from the member of staff who's come along to help you, which could hopefully be a senior nurse or a doctor. Although we have presented the A2E as a linear assessment, it is actually a process by which we ensure that we don't miss anything. Yes, we follow the order, but things may change and you may have to jump to and fro. For example, you may approach a patient and notice that a wound drain is completely full of fresh blood, which actually falls under E, but you still need to think about A, B, C and D. However, during this process, the patient's status may change, and even if you are not initially particularly concerned, if you then feel like you need it, call for help. My recommendation would be that if you feel a patient is deteriorating, call for help sooner rather than later. I hope that you found this reminder of the ATE approach in managing a deteriorating patient useful. There are further resources available on the Acute Care Team website, and it is hoped that face-to-face teaching will resume soon. In the meantime, please can you complete and return via email the short quiz as provided on the website to register your utilisation of this session. Thank you.